This podcast is for informational purposes only and does not dispense medical advice. Always seek the advice of a physician or other qualified health providers if you have any questions regarding a medical condition. Never disregard professional medical advice or delay in seeking such advice because of something you have heard on this podcast. Welcome to a show that we like to call Prostate Cancer Real Talk. Did you know that in the U.S., 1 out of every 8 men will be diagnosed with prostate cancer during his lifetime? 1 out of 8. And black men are 50% more likely to develop prostate cancer in their lifetime and twice as likely to die from the disease. But hey, we're not here to quote statistics and tell you how tough prostate cancer can be. Rather, we are here to create a supportive community of survivors. A place where we can discuss the real-life coping methods from the perspective of a married couple who are living through it day by day. Our hosts, Elle and Shay. This is Prostate Cancer Real Talk.
In this episode, we welcome Dr. Kirtland Deville. Dr. Deville is an associate professor in the Department of Radiation Oncology and Molecular Radiation Sciences at the Johns Hopkins University School of Medicine. He serves as medical director of the Johns Hopkins Proton Therapy Center and clinical director and chair of Sibley Radiation Oncology. Dr. Deville's clinical expertise involves treating patients with prostate cancer and soft tissue sarcoma. His funded research interests include improving tumor targeting and assessing toxicity profiles using modern radiation techniques such as proton therapy. He has authored over 170 peer-reviewed publications and serves as a deputy editor for the International Journal of Radiation Oncology, Biology, Physics. Dr. Deville is also a leading voice in health equity, diversity, and inclusion, or HEDI, in radiation oncology. He led the formation of the American Society for Radiation Oncology's, or ASTRO Council on HEDI, and was recently elected to the ASTRO Board of Directors. Let's welcome Dr. Kirtland Deville. Ellen Shay, take it away.
Thank you very much for that wonderful introduction, Dennis, and welcome to Dr. Deville and also Shay. Hello, doctor.
Hi there. Thanks for having me. It's a pleasure to be here.
Well, first of all, I'd like to say that is some kind of resume.
Yes.
That you have there. Tell us a little bit about your story.
You know, no one in my family was a physician, a doctor. I was the first generation in terms of going to graduate school and that sort of thing. So when I always knew I wanted to be a doctor. I went to medical school and really didn't know what specialty I wanted to do. I had an interest in sports medicine and those sorts of things. But it was really when I was doing my rotations as a medical student that I realized I was drawn to the patients with cancer. I was drawn to oncology for whatever reason. In fact, I only understood it in hindsight and sort of looking back and really sitting down and thinking, because I had sort of this moment where I realized I didn't want to be an orthopedic surgeon. So what was I going to be? That surgery didn't speak to me in that way. And when I reflected back on my rotations, I realized in every specialty that I rotated through, I was always most interested in the cancer patients, whether it was medicine or surgery or OBGYN or any specialty, because really almost every specialty has an oncology branch because almost any cell in the body can become a cancer. And so that led me to oncology, and I was working with some oncologists during a clinical research year at Yale, and they referred a lot of patients to radiation oncology for radiation treatment. And radiation is quite an obscure specialty. A lot of people don't know about radiation. A lot of medical students and physicians don't get exposure to it in their training. So I was sort of lucky that I did get that exposure, and I thought it was really great. It was kind of an intervention-based specialty, kind of like that surgical mindset of I have to create a plan and deliver that plan. And it's very anatomy based. You have to understand the anatomy. Where's the cancer starting? Where might it spread to? So, and then you have technology, you have gadgets and tools and things that are constantly evolving and improving. And so all of that sort of melded into the perfect specialty for me to be able to work with cancer patients. So I did my residency in radiation oncology at the University of Pennsylvania in Philadelphia. And it was there where I really got drawn to prostate cancer. And the reason was I did my first rotations at the Philadelphia Veterans Administration Hospital. So the Philly VA is covered by the University of Penn. And so immediately I was, kind of struck there in West Philadelphia. and seeing a lot of Black men. They would assign, there was a junior resident and a senior resident, and junior resident saw all the prostate cancer patients. So here I am, the only Black male in my program, seeing all these Black men with cancer, with prostate cancer specifically. And that sort of really struck me, sort of wondering what's going on, to the statistics that you mentioned in the beginning, higher incidence, higher mortality. And back at that time, I don't think the conversation was not as evolved and to the forefront as it is now and as it should be, understanding these statistics. It was almost as if you shouldn't really be talking about race and disparities, and you should focus on the biology and just sort of those aspects, and not sort of bringing the full picture together to really understand what's going on. And I did my rotation then on the main campus early on, also in prostate cancer. So from the outset, it was kind of destined that I was going to focus on that as a specialty. And as radiation oncologists, as I mentioned, we treat all types of cancers. You rotate through all of the subspecialties, learn how to treat cancer across the body. But as I was finishing, decided I wanted to have that focus, and was fortunate to stay on as a junior faculty member there at the University of Penn before I came over and joined Hopkins. So that's kind of my journey to radiation oncology and to prostate cancer specifically.
So as we were chatting before the show here, we talked about radiation versus radiology. And you gave us a lesson, because I think I mispronounced one of them and you took me to school. So could you tell us a little bit about the difference between radiation oncology and radiology?
Yeah, absolutely. And I take the opportunity. One, when I see patients in consultation and in the clinic, I say, hey, I want to make sure you are fully informed and educated and feel confident when you leave this room. They say that's Dr. Deville's patient. They know he's well informed. He knows about his cancer. He knows what matters, what doesn't, the indications. But I want them to feel really engaged and informed, and not leave confused or like there's something they don't know. Always, of course, there's always questions that arise, but so specific to that question, patients often come in and say, you're my radiologist, or this is radiology oncology, those sorts of things. So I just take the opportunity to clarify. Technically, I'm a radiation oncologist. Radiation oncology is its own specialty that can treat prostate cancer and can manage prostate cancer. We can be your primary, oncologist, your primary doctor once you're diagnosed with treatment. Radiation oncology became a specialty out of radiology. So back in the day when X-rays and radiation, the ability of radiation was sort of being discovered, I'm talking about, almost over 100 years ago, there's sort of always been an imaging branch and a therapeutic branch. So diagnostic and therapeutics. And eventually somewhere, I think in the 60s or so, the field split, and radiation, and then providers. So providers used to do both. Radiologists would do both imaging and therapy. And eventually it split, and if you decided whether you wanted to do sort of therapy training, which became known first as radiation therapy, and then eventually radiation oncology. And so radiology obviously still exists as its own branch, and those are diagnostic radiology. So they're usually sort of diagnosing, taking imaging scans, things like that. And radiation oncology is the branch that's handling the therapeutics, the treatment, the management. There's obvious overlap. We use imaging to design our treatments, to target tumors. So we get training in imaging. And overall, the American Board of Radiology is who certifies both diagnostic radiologists and radiation oncologists, and technically interventional radiologists, which is a third specialty within its own specialty within radiology.
Just a reminder, to ensure that you stay up to date on the latest episodes from Prostate Cancer Real Talk, don't forget to hit that subscribe and like button.
So to demonstrate this in kind of like a practical term, as you were talking, I was thinking about, somebody that goes and gets an MRI or an X-ray or something like that. The radiologist would read and interpret those results.
Exactly. The radiologist is reading that prostate MRI that we're going to talk about, and working with the urologist who may be doing a targeted biopsy or just referring the patient for their MRI. Once that pathology, the information is known on the cancer, and the patient is deciding on their treatment options, then they will come and see me. They will come and see a radiation oncologist who would actually design the treatment.
So I'm going to ask the first question here, and then I know Shay has some questions for you. As we're talking to men and our listeners about the decision surgery versus radiation. Okay. And I'll just use my own story as an example. When I was discovered to have prostate cancer, we had a choice on how we were going to treat it. Were we going to go with radiation or were we going to go with surgery? One of the key decision makers for me was when my surgeon told me that once you elect radiation, then surgery becomes, he didn't say impossible, but more challenging and difficult down the road. So can you please talk to us about surgery versus radiation and some of the things that people should consider, a man and his family should consider when they're making the surgery versus radiation decision?
Yeah, absolutely. This is, frankly, the conversation I have, all day, every day, seeing patients now, some thousands of men with prostate cancers are working through this decision making. I want to address the last part first, and then I kind of take it back to the beginning, because I think it is really important. What you talked about, this idea of what happens if you need additional treatment after your first treatment. And there is some, I call it phraseology. I don't want to say the physician is saying something wrong or, sort of fully incorrect, but this statement that this idea that, well, you can have radiation after surgery, but you can't have surgery after radiation. Or technically you can have surgery and radiation, but it's very morbid. It's, there's a lot of complications and risks. That's often kind of said and left there. It sort of implies that there are not alternative options that are just as good at eliminating the residual cancer that might be left behind in the area where you had radiation treatment. So I hear that all the time, day in and day out from patients. And it's a little bit frustrating because it's somewhat misleading to sort of imply that there are not alternative options that are just as good. So
I just want to clarify something.
Yeah.
When you say you hear that all day long, the question that you're saying is that you hear that people are saying, once I get radiation, I can't have surgery. Is that the question that you're paraphrasing? Okay.
Yeah. And that's what's been told to them by their surgeon. Not to throw the surgeons under the bus, but that's what's been told to them. And it's not an incorrect statement to say that you would be unlikely to have surgery after radiation. I wish the additional sentence was said with it. You wouldn't have that because you have other options that are just as good at eliminating the residual cancer that are not as aggressive and morbid. There are things like cryotherapy, high frequency ultrasound ablation, focal radiation, repeat radiation. There are other treatments that we can have. This falls into a category of what we call salvage therapy. So again, that concept of what if your first treatment, doesn't work, I put that in air quotes. Mm-hmm. It's just that there's some residual persistence of the cancer locally. And what do you do? And so I say that because I don't want, and I tell the patient this directly, I don't want them to be driven by the thinking that I need to have surgery because I don't have a backup option. That's incorrect. You can have surgery because it's a good option for you, right? But don't sort of make a decision thinking that this is somehow the better option because you have a backup option that you don't have with the other pathway. So when we sort of back up and say our outcomes are just as good, whether we have surgery or radiation, that includes the idea of needing salvage therapy, of any salvage therapy, because if you had better outcomes with surgery followed by radiation, that would show up in the recurrence rates, the survival statistics, those sorts of things. When we can say that your outcomes are just as good, whether you have surgery or radiation, that includes the idea of the need for any salvage therapy.
Okay. So fortunately, I'm coming up on my 4-year anniversary from surgery. And just this past week, I went in for a follow-up PSA test. Mm-hmm. Mm-hmm. And of course, when you're waiting on that test, that period that you're waiting for those results can be stressful.
Yes.
And so thank God, first of all, Northwestern Medicine is my care facility. They get you your results back so rapidly. I had my test on a Friday, and Sunday I got the results back via email, and my result was that less than arrow, less than 0.01, which is interpreted to be undetectable.
Exactly.
Okay. Exactly. So, I feel really great about my surgery option. But what you're saying now is that had it not come back at 0.00, and if we had to go back and for a follow-up, we could have done that surgically. And what you're saying is that same option holds true for someone who may have gone in for a radiation treatment.
Yeah.
They still have options.
Exactly. So just to sort of be a fit, just to kind of clear up what you said. So if the PSA is rising after surgery, then, one of the options may be to do radiation to that, what we call the prostate bed, the space where the prostate was removed. And so that's a standard option. And you do, in the other sort of reverse scenario, the patient had radiation first, they're being followed, PSA goes down, but then starts to rise. If there's some cancer that's, picked up that's still active within the prostate, there are local therapies that can be delivered to the prostate and have just as good outcomes. Yes.
Okay. If a person has radiation instead of surgery,
yes.
Talk to me about that, because we don't really know anything because we went the surgery route. So talk to me about the process of going through radiation to treat prostate cancer.
I'm not an expert in it, but there are people who are dedicated to this question. There's a whole field of treatment decision-making, treatment regret, those sorts of things in prostate cancer management, and that's sort of more understanding the psychosocial and how, in terms of outcome, physical outcomes, but also, mental and quality of life and those sorts of pieces, because you have multiple options. Sometimes I tell the patient, you have a menu of options to choose from. We are not going to end this conversation by saying this treatment is better than that treatment. We're going to end with that menu. And our job here is to think about what suits you best. What are you a good candidate for? But sometimes you can be a good candidate for everything. Understanding what you're a good candidate for, and then working through in what we call the shared decision-making process, me understanding your values, what you seem to be prioritizing, and which of those options might best suit that. Because at the end of the day, many patients are going to end by saying, well, Dr. Deville, what would you do? Or when I was younger, they would say, what would you do for your father? Now they just ask me, what would I do?
Oh, you still look young, so.
But back in the day when they would say, what would you do for your father? I would say what my father would do is different than what my uncle would do in the exact same scenario. So it's not about me imposing my bias. It's really thinking about the individual. What am I hearing from you and what may suit you? It may be radiation. It may not be radiation. It may be surgery. And I say, go have your surgery. You're great. Looks like you're a great candidate for that. So I think, it's unfortunate when I do hear, that's why I'm so happy to be here in this conversation today, because I often do hear that, patients, have to stumble on their own on radiation oncology or about, hearing about brachytherapy, the internal radiation, the seed implant, or things like proton therapy, sort of unique things within radiation treatment. And they're not necessarily being referred. Generally at most, hopefully most academic medical centers or sort of larger practices in work in oncology, we want to work in multidisciplinary teams and in a multidisciplinary fashions. Most studies show you have better outcomes when you work that way in oncology. And so, we are fortunate to partner with our urologists, and they refer us to patients just to hear about radiation, just to make sure they've heard about it up front. And I may often do that. I may see a patient as a second opinion, coming from another institution. They want to hear about radiation or protons or something very specific. But if it sounds like, I ask them, have you been well counseled on surgery? Do you feel like you've heard about that? Do understand the outcomes? And if they say no, I'll refer them right away to one of our urologists to make sure. I want them to, like I said in the beginning, I want them to be fully well informed about their cancer, their treatment options, and all those sorts of things, whether they're ultimately getting treatment with me or not. But let me walk it back to the beginning of how do we understand or think about radiation treatment? Mm-hmm. So usually by the time I see the patient, they've been, just as you told your story, they, been screened or diagnosed, we understand the Gleason score, their cancer. So we're sort of putting it all together to understand what their management options are. We use nationally and internationally, if the cancer has not spread, so we're talking about a localized prostate cancer, because if it's spread, they're off to see a medical oncologist, get hormones and what we call systemic therapy. And they're not really focused on radiation or surgery, like a local treatment option. But if the cancer is localized, meaning we don't see any obvious signs of spread or sort of contained within the pelvic area, they're going to be a candidate for curative treatment. The curative treatment pathways, I tell the patient, is surgery or radiation. You can take the surgery road or you can take the radiation road. So for the surgery road, I'm going to let the surgeon focus on that. I'm going to make sure they're well counseled on what are the logistics, the risks, the operative risks, the side effects, what's the techniques that's being used, are the nerves being spared, all those sorts of things, really making sure they understand that. And in fact, has the surgeon told them they're a good candidate for surgery. With radiation, I'm going to focus on that pathway and talk about the various forms of radiation. But one of the key things I wanted to say, so nationally or internationally, we use what's called the risk group stratification, right? So we need to classify that person's prostate cancer to know what are the appropriate treatments for it. And so that's defined as low, intermediate, or high risk. And it takes into account your PSA, your Gleason score, and your tumor stage, right? And so a person with Gleason 6, usually I tell patients the Gleason score, that marker from the biopsy tissue, the score that was assigned to those cells, marker of sort of aggressiveness and risk, its potential to spread. That Gleason score is historically the number one predictor of long-term outcomes. That's why we put so much kind of focus into it. So that Gleason score that the pathologist assigns when he looks at those slides under the microscope, that worst Gleason score is what usually drives that risk group stratification. So if it's a Gleason 6, 3 + 3 = 6, pattern 3 are the cells that are the least aggressive appearing and don't really tend to spread. So that's Gleason 6, low risk prostate cancer. Nowadays, the number one management for Gleason 6 low risk prostate cancer is no treatment, is what we call active surveillance, monitoring, close monitoring. I used to say historically it was watchful waiting. Now we changed that term because watchful waiting was, go away and come back when you have a problem. We know we don't want that. We want to keep a close eye on the patient. So active surveillance is we're going to keep a close eye on your prostate cancer, and we're only going to treat it when it's showing signs of becoming more aggressive so that we don't have a problem down the road like spread or death from prostate cancer. That's usually something like a PSA every 6 to 12 months, a biopsy, an MRI every year, so that, again, you can kind of jump in at the signs of earliest progression of the cancer. So that's Gleason 6 low-risk prostate cancer. There are some scenarios where they may move on to treatment earlier, or we might sort of think about still treating, but just at a sort of basic level, that's what's happening. That's the primary recommendation for low-risk prostate cancer these days. And the urologists usually follow the patient in that setting. So we don't even really see those patients anymore. With Gleason 7, that's defined as intermediate risk prostate cancer. So now the cells are behaving a little bit more aggressively. They have the potential to spread, invade locally or spread. And so that's where we're recommending treatment. Unless the patient has a life expectancy less than 5 years, then you may just kind of do a monitoring strategy. But if more than that, they're likely going to live long enough that the cancer could cause a problem in their lifespan if you don't do something about it. And so that's where we're doing treatment. And then the next category just beyond that is high risk prostate cancer, which is if your Gleason score is 8 to 10, that's as high as the scale goes, that those are the patients that really have a higher risk of cancer progression, and they need more comprehensive treatments. The one thing I will add is, so we use the risk group also to say whether the patient is a good candidate for surgery or radiation. In the high-risk group, especially if it's what we call very high risk, there's already signs, say, on the MRI or on the PET scan, the imaging scan, that the cancer has spread to, through the shell of the kind of capsule of the prostate into the glands that sit on top called the seminal vesicles, or if it's in an adjacent lymph node, the lymph nodes that are sort of beside the cancer, the prostate that, the cancer cells like to try and escape. They're trying to figure out ways to escape the prostate. If we see any of those signs, very often those patients are less likely to have surgery. They're actually more likely to have radiation because we're already seeing signs of the cancer moving beyond the prostate. So all of those things are what we're sort of analyzing and thinking about and explaining to the patient as what influences whether one treatment might be better for them or not. But in principle, like say in your situation, very commonly in that intermediate risk box, they're going to have the options of surgery or radiation. So then I tell the patient age can become an important factor, because age is often kind of a surrogate for other medical issues, how the patient is going to tolerate and recover from surgery. So sometimes you hear things like everyone over 70 is kind of steered towards radiation, everyone under 60 is steered towards surgery, and 60 to 70 goes either way, depending on their overall health status, their personal preference, their other medical issues. And so, right, if you're in that 60 to 70 box, you're right in the middle where you could go either way, depending on these factors. Some of the things that influence the age piece are kind of what I was mentioning, that ability to tolerate surgery. Over age 70, if the person has multiple medical problems, there may be risks of anesthesia, things like wound healing and recovery, in diabetics and other patients may present issues. And actually the recovery, the rates of leakage and incontinence. So, right, the person after surgery is wearing a pad, they may be dribbling or just leaking, not have control. And generally young men and very young men will recover well, not even have any leakage or minimal, and do their Kegel, their sort of strengthening pelvic floor exercises, and not need a pad. But those rates of not recovering go up with age, particularly over age 75. So that's why very older men are generally not going to be advised to have surgery. On the flip side, very young men are generally going to have surgery because they're going to tolerate, they're going to recover well. Especially if they don't have very advanced disease, the cancer is entirely limited and contained to the prostate, and they can hopefully be one and done. I always tell patients, because sometimes they say, oh, it can come back after surgery. Absolutely, it can. No treatment is 100%. Those cells could have escaped the prostate. But, hopefully they'll be able to, if they're very young, cancer's unaggressive, they can just have the surgery. And one of the rare risks with radiation that does not, it's maybe not at the forefront of the conversation sometimes, but can be important for very young men, is the risk of creating a new cancer from radiation treatment. And so anytime, one of the ways radiation works is creating DNA damage. The cells are made of DNA. Cancer cells are constantly dividing. They're more likely to have their DNA exposed. We hit it with radiation every day, cause DNA damage, and those cells die. That's how radiation just fundamentally works. But if you have normal cells that are dividing, and get DNA damage, they may get mutated and not die off. And that could years down the road, become a cancer, maybe like 5 to 10 years at earliest. So we usually quote like 0.5 to 1%. The risk is very low. But, I tell patients, you treat hundreds or thousands of patients, statistically, somebody is going to be that person who gets that secondary cancer 5 to 10 years down the road. So for very young men who have decades and decades and decades of longevity, if it's a 50-year-old, you're projecting 35 years of longevity in the United States, that might be a bigger concern, that risk, than say a 75-year-old where you're not projecting the same lifespan. And so those are things that can influence that decision-making, and why very young men often have surgery. And we as radiation oncologists are not sort of arguing with that at all. We know that in balancing those factors, that's likely very appropriate.
So you mentioned, during your explanation, there's another factor that I considered in my decision, and that was the frequency of the radiation treatment. We happen to live an hour away from my care facility, and I understood that the treatment was weekly to, even more frequent. Can you talk to us about the frequency of the treatment and how that factor plays a role in the decision-making on treatment versus radiation?
Definitely, yeah, in the surgery versus radiation question. So yeah, the logistics of treatment are important. And so, although I'll say, you have to recover from surgery. You got a couple of weeks that's going to impact your schedule as well, and sort of thinking about those things. But nonetheless, so for radiation, we have internal radiation and external radiation. Internal is called brachytherapy, or sometimes people say brachytherapy, but it can be done, historically, it's more commonly done with seed implants. So a lot of people have heard of seeds, or a friend of mine had these seeds. What are the seeds about? For internal radiation, or it can now be done with catheters. So seeds is called low dose rate, catheters are called high dose rate. So you'll hear LDR, HDR, so the acronyms people throw around. The benefit of the catheters, a lot of people have sort of moved to doing that more commonly, or as a preference now, where the radiation doesn't stay permanently in your body. So seed implants go in and the seed stays in permanently. So the way that's done is in an operating room or a surgical suite, and kind of similar to the biopsy, an ultrasound probe is used to guide the needles right through the skin of what we call the perineums, that space. If you sort of lift your scrotum, right behind there is where your prostate is. So you stick a needle right through there, you can deposit radioactive seeds, and those seeds stay in the perm. So you cover the whole prostate, they stay in permanently decay over time. So there are some precautions that have to be made with radiation exposure, just kind of radiation safety things, and the patient's given some guidance, like how long a period they might need to use a condom, like a barrier method for intercourse, or don't, sit next to pregnant women, or don't put a child on your lap. Sometimes there's some psychosocial restrictions that the person says, oh, I have the grandbaby and this, that, and that's not going to make sense for me. With the catheters, they do it the same way. They put the catheter with the needle into the prostate, deliver a radiation source there, expose the radiation to the prostate, and then they pull out the catheter and the needle. And so the radiation is not in the body. It was just temporarily exposing the cancer and killing the cancer that way. But nonetheless, that's invasive. So if somebody wants to avoid an invasive procedure, they're usually not going for the internal radiation. Convenience-wise, schedule-wise, that might be more similar to surgery, where the person feels like, oh, well, I can go have this one procedure done and I don't need to come in every day for this external radiation. So the external radiation, which is what's done more commonly, is done usually they're scheduled. So historically, it had to be 8 weeks, daily Monday through Friday treatment. So it was a long schedule, even 8 to 9 weeks sometimes. I tell the patient, you're in a department for about an hour, you're in the room for like 20 to 30 minutes. The treatment's, the fastest part, 5-10 minutes. So it's just like any x-ray or CAT scan. You arrive, you check in, you get changed, you get called back, you get set up in the treatment room, you lie on a table, you just hold still, you lie flat, hold still. The machine's going to do all the work rotating around you, delivering. We, sort of target the radiation to the prostate. You don't feel anything, see anything. There's no pain. There's no immediate sensation to the treatment. So you can work, exercise, whatever you do on a daily basis, you can continue doing. So the biggest hassle with the radiation is having to set aside that time period. But otherwise, you can continue your regular routine. We now can compress the radiation schedule. We used to do 8 weeks, but now more commonly, the more common regimens are something like 5.5 weeks, like 28 treatments, or 4 weeks, like 20 treatments. And then there's some really compressed regimens where you can get it in about a week and a half. You can get 5 treatments, often done every other day. That's called stereotactic radiation, or sometimes people have heard of cyberknife or radiosurgery. That's one form of stereotactic radiation. I always say there's good branding. So that's one machine. There are other machines that do that. Other vendors, Varian, Electa, other companies also do create those machines. But all of that comes down to patient selection. Who's a good candidate for these treatments? Because you can imagine when you compress the schedule down for radiation, you're delivering the same amount of radiation, you're just giving it in a shorter period of time. So I tell the patients, kind of if you think of like a boxer, the slower we go, the lighter the hit we're giving every day. We go faster, we're giving a harder hit, but you might increase the risk of side effects. So if someone has, a lot of medical, maybe they have a very large prostate, a lot of urinary problems coming into treatment, or bowel issues or things like that, you may not want to do one of these more sort of aggressive, accelerated regimens. But the most common regimen nowadays in the US is the 4 or 5.5 weeks, the 20 or 28 treatment regimens. So it is, it can be burdensome to the individual to set aside time in their schedule if they're working or got family obligations or whatever it is, to need to come in every day for the treatment like that.
So, got to ask this question. And I know you hear this. Yeah. You could probably anticipate where I'm going with this. Sexual side effects.
Yeah.
As a matter of fact, some men avoid treatment at all.
Yeah.
Okay, because the potential, which is kind of a crazy decision in my mind, because you're literally choosing life and death.
Yeah.
Let's talk about, if I'm concerned, or if a man's concerned about the sexual impact of treatment. Is radiation better than surgery, or surgery better than radiation? What are the sexual components to both?
Yeah, no, it's a great question. And this is, the exercise that we should have. So I'm glad you're asking when I'm, sort of talking to patients, trying to understand what are they going to value and preference more, because everybody's different. One guy may not be worried about erectile function. They may be more concerned with leakage and incontinence. Another guy, that's their highest priority, is what is their erectile function, right? If we think, there's sort of 3 main domains of side effects, whether you have surgery or radiation. We can think of the urination, like how are you peeing, basically. The bowels, bowel function, how are your bowel movements? Are you having any bleeding or urgency or accidents or things like that? And then the third domain is the erectile function. And each treatment has kind of its own profile. There's always trade-offs. Like no one treatment is perfect that has like no side effects and that sort of thing. So for surgery, leakage and incontinence is the bigger issue with urination, sort of loss of control and needing to recover from that. I would say radiation for men who have a prostate doesn't usually cause leakage and incontinence. Instead, we cause what we call irritative symptoms. I have to go more often. I can't hold it as long. I'm running to the bathroom. It's more urgent. I'm getting up at nighttime more, or my stream might be more intermittent or diminished, things like that, sort of qualitative. And then, of course, there's medications and things we can do to try to manage that, or to help manage that. With the bowels, surgery, I always tell the patient, surgery wins on that one. They tend to not, or it's rare to have bowel complications during surgery, so they're really not, usually having any issues. And radiation may cause, because the prostate is right in front of the rectum, that's the earliest part of your, or one of the last parts of your colon, I should say. You might get some irritation of the rectum that manifests like bleeding, or what we call proctitis, inflammation. It can look like hemorrhoids, I tell the patient. They wipe and they have, blood, or they notice blood in the bowl, things like that may happen, which again, we can manage. And these are sort of less than 10% risks. They're pretty uncommon, but they do happen. The erectile dysfunction one is often important. So let's go there for sure. And that's why I tell the patient, neither is going to win. The quality might be a little bit different. With surgery, you may tend to see more impact earlier on. One, again, it's important to know, is the surgeon sparing the neurovascular bundles, what's going on? And that has to do often with the extent of cancer, where's the cancer located, those sorts of things. But you really do want to ask the surgeon sort of, what do you think in terms, what are my rates of leakage and incontinence, but also my erectile function and potency going to be? Because usually men will have some decline and then they'll have some recovery over time. And observational studies show this. I'm sort of creating figures or graphs as I'm talking, but there are observational studies that show this. Radiation is kind of the opposite. Most men, especially if they don't need hormonal therapy during their radiation treatment, which I haven't talked about, but temporary suppression of their testosterone, sometimes we use that with radiation to improve the cure rate, to help kill more cancer. That causes some temporary loss of erections. But if they don't need hormonal therapy, if the cancer is less aggressive when we treat it and we're just doing radiation by itself, they don't tend to see any impact on their erectile function during the radiation treatment. It's more like 1.5 years or 2 years down the road, they may see some decline in the quality or quantity of their erections. So it's unusual to say something like, I suddenly lost my erections. Mm-hmm. It's more like, I don't get as many, they don't last as long, they're not as rigid. So both specialties, quote, about 1/3 of men will see a decline in their erectile function. But again, the picture is a little bit different in terms of how that goes. Most importantly, there's usually options. So if patient has radiation, and they can use medication, especially if they never needed medications before to help erectile function. The very common medications that we hear about, sildenafil, tadalafil, which now have generic versions and are less costly than they used to be. But those things usually help if the patient didn't really have any issue before. If they had issue before, we're already on those medications, well, then I'm telling the guy early on as I'm seeing him, hey, down the road, 2-3 years down the road, those medications may not be working. And we're going to have to talk about more invasive things like injections or a pump or an implant. There are always options if the patient is that motivated to pursue them. Like I said, some guys will say it's not important. Other guys, that is the utmost importance to them.
Don't forget to subscribe to our YouTube channel and like this video to keep seeing more content like this from us. It will also benefit YouTube's algorithm, helping to introduce our content to others who may need it most.
So in radiation, Dr. Deville, so I did a little research and I see that there's scarring. Now, what does that do to the patient afterwards? How does scarring, impact them?
Yeah. Well, I do use the analogy of scarring like with surgery. So I tell the patient that, it's just like when you have surgery, there's a scar there. There's physical evidence that a procedure was done, that something was done, and the tissues have to heal. And so they may have, we call that fibrosis, tightening, but that's essentially what scarring is. Now, really what matters is, does that scarring impact any function? Are there any symptoms related to that, right? Because if you just have a scar and there's no other problem, you're going to be hopefully okay with that, or you understand that there's a reason for that. I think the issue is more if that scarring leads to problem, just like surgical scarring with surgery on the insides where someone has had surgery may cause things like obstruction or adhesion. So maybe down, years down the road, a rare complication, they may have like a bowel obstruction or something that needs surgery to correct it, right? So that's the same thing with radiation. There are rare risks related to scarring. The impact of radiation itself, just because you have radiation exposure, doesn't necessarily mean it has to cause sort of a problem with scarring or burns. Sometimes I hear, patients describing, which is not really an issue with this treatment, since radiation is done deep in the body and not showing sort of superficially on the skin. But like, and let's talk, an example of scarring might be something like with the urethra, the tube that's draining the bladder, the urine, and runs right through the prostate. Both surgery or radiation can cause scarring and cause a narrowing, what we call a stricture. And so the guy out of nowhere, 2-3 years down the road might say, hey, I'm having to pee and my stream is weak and it's intermittent and the flow is just different. We can do some imaging tests, or ultimately the surgeon can go in with a camera, kind of like a colonoscopy, but they're going through the urethra and doing what we call a cystoscopy, and they might see that narrowing. So that can after surgery or radiation, and then they can just stretch and dilate it back open. And so there can be, in radiation, we usually quote a 3% risk of all the patients we treat. It's about 3% risk that they might have a stricture, a urethral stricture that requires a dilation procedure, right? So a lot of times also patients, it's never good to say there's side effects or there's risks or those sorts of things. But at the same time, we want to reassure them that there are procedures, there are treatments, there are things that we can do if we're picking up some of these late effects, these long-term complications, or what we call toxicities, which are just sort of late side effects. Yeah.
Okay. So I think like in both then, if a guy, because we're talking to guys that are younger, being, diagnosed with prostate cancer. So I'm thinking about families now. So I think that younger guy, maybe in their 40s, if they're still like want to have kids, so then they probably should preserve their sperm then, right?
That's absolutely important. And we don't, and I kind of say, I don't want to like a judge either, because sometimes I'm surprised I get a guy in his 60s who either has young kids or says they are also worried about fertility preservation. So that is important, whether you have, any treatment you're going to have for prostate cancer. If you're concerned with your future ability to conceive or have kids, you should do what we call cryopreservation with sperm banking. Basically, you should absolutely do that. Because your fertility, specifically your ability, is going to be reduced or compromised, whether you have surgery or radiation treatment.
So are you seeing more younger patients? Because we actually, like my mom, her neighbor, he passed away maybe like 4 months ago. Yeah. He was 44 years old and he died of prostate cancer, undiagnosed or untreated prostate cancer.
Yeah, no, unfortunately, we are seeing, earlier, younger men diagnosed sooner. It's kind of extremely rare, almost unheard of under the age of 40, but definitely those, very early, in the early 40s, seeing patients like that. And unfortunately, it tends to be more aggressive when they're diagnosed at a very young age. There's not really, the screening guidelines generally don't sort of routinely recommend screening that early, although if somebody has a family history of a very young patient, then they do say to check a PSA 10 years before that person was diagnosed. So that sort of 44-year-old's family member should be starting very early at 34. The problem is they're often not getting that counseling and having awareness that they need to be starting so soon in terms of their screening.
Okay, so thank you very much, Dr. Deville, for your incredible information. And I can tell right now, we need to come back to you and hopefully fit back into your schedule, because I'm sure there was a lot more that wasn't said.
Yeah, because I have more questions.
I know. And I don't want to get in trouble with Shay, because I know she has some more questions.
Yeah.
So we'll have to work with you about coming back. So we know it's time. So thank you again for your time, for this great information, and we'll see you next time.
And Dr. Deville, I tell you, it's our podcast, but this is an episode that I will probably, as the host, listen to at least a good 5 to 10 times, because you're just that deep, dude. You're amazing.
That's great. I appreciate it so much. I'm happy to come back anytime. Like I said, we don't, as radiation oncologists, don't get that opportunity, so much to speak directly to the people, to the patients. I really enjoy doing it. And there is a ton more I feel like I could have talked about or shared. So I'm happy to come back anytime.
We're definitely going to do it.
Yes. All right. Yes. All right, Dr. Deville. Thank you. And thank you so much for being on the podcast.
Thank you, guys.
To find out more information on the guest you just heard or previous guests and a list of Prostate Cancer Real Talk episodes, visit our website, prostatecancerrealtalk.com. And if you have a question, comment, or if you would like to share your story, send Elle and Shay an email, ellandshay@prostatecancerrealtalk.com. That's L-E-L and Shay, S-H-A-Y, @prostatecancerrealtalk.com.